Welcome to AT Corner bonus content for the femoral acetabular impingement episode. So for this content, what we're going to do is we're going to go over the special tests that we were talking about in the episode, some manual therapy techniques that you can add to the treatment of FAI, and then some rehab exercises for evidence-based isolation of the gluteal muscles without influence from the hip flexor muscles. All right, let's jump into it. So the first special test is going to be the FADIR test. So what you'll do is you'll have the patient for the affected side, you're going to have them go into full hip flexion, and then you're going to induce adduction and internal rotation. A positive test is pain right around the hip. This differs from the anterior impingement test, which instead of going the full flexion, you go about 90 degrees of hip flexion, and then same thing, adduction, internal rotation. A positive test is pain. As we mentioned in the episode, these tests are good for ruling out FAI. So if we do both these tests and she has no pain at all, you can have a lot of good confidence assuming that FAI isn't present. Now, if she has pain with any of these special tests, if they're positive, now you just know there's hip pain in the area. So you'll use your other tests to kind of figure out, to help identify FAI. And one of those, what we talked about, was combining a range of motion test, and one of the better ones for sensitivity was actually testing internal range of motion prone. So we'll have you go and flip onto your stomach. So to test internal rotation range of motion and going prone, essentially it's basically like a dial test. You'll just be here, and then you just have it here, bring your legs out, and then you'll measure the range of motion with the goniometer, or you can eyeball it to see if one's different than the other for internal rotation range of motion for the hip. So now that you went through the evaluation process of trying to identify FAI, and now you feel like, yes, I think FAI is happening, or at least there's some pathology in the hip. Now what we want to try and do is actually treat the affected hip. So one way to start is with manual therapy. Manual therapy has shown pretty good results for hip osteoarthritis patients. For FAI, it's a little iffy, but it is a nice way to add into treatment, especially if there's actual internal rotation deficits. And plus, some patients respond very well to manual therapy, so if it's able to decrease their pain a little bit, it's worth a shot. So the first one we can do is going with the hip traction. So what you'll do is you'll have the patient's affected leg bent just like this. You'll grab a nice little mobility belt. Make sure the pad is pretty close to joint line, as close as comfortable for the patient. Then you buckle up for safety. The buckle should be right around where the glutes would sit, so you're taking stress off of your back and giving a nice good pull. I'll bring the patient up to around 90 degrees. Stabilize the hip, and then you just add a little traction just like that. What I like to do in this position is I like to add some motion there. So I'll kind of go internal, external rotation, just small little motions, trying to get the synovial fluid to start flowing throughout the joint, help getting nutrients within the joint. I'll go you can do 3 sets, 30-second holds. You can do 3 sets of 10 of just rotations, whatever you like to go with. From here, what I like to do is I like to add in a little posterior mobilization as well. So I will shift my weight this way, and then I'll actually basically pull the head of the femur in a posterior fashion, and now I'll sit it down like this, and you're still getting that lateral traction as well. So another way you can do it is, that's one way to do it for a mobility belt. If you don't have a mobility belt, what you can do is you can also just do simple long bone traction, just kind of going through that long axis. You're not getting like a great true distraction out of the joint, but this is still help clearing that impingement area and just going here and just pulling out just a little bit. You can, same thing, 3 sets, 30 seconds. You can add small little motions to help the fluid, with the synovial fluid within the joint, to help circulate and get nutrients throughout the joint. So now that we did our manual therapy, help decrease some of the pain, help improve some range of motion, the next thing we have to do is now let's work on our rehab exercises to help protect the joint itself and correct some muscle imbalances that we've seen with FAI. As we talked about in the episode, you do see decreases in hip abductor strength, hip adductor strength, so it is a good idea to start working on the glute muscles. especially if there's an imbalance between those hip flexors and the glutes themselves. So what we'll try and do is try and show some basic ones first and then kind of go advance from there. The first one is the glute bridge. So with the glute bridge, you'll have a resistance band around their knees, just above their kneecaps. I like to have their heels as close as they can to their butt to really try and maximize the glute contraction as opposed to the hamstrings. They should be feet shoulder width apart. And then how I like to cue them is I like to have them get a nice abdominal brace, so as if they're doing planks. And then I just remind them that they don't have to spread their knees super far. They're really just applying tension to the band, holding that tension, and then finally add in the glute bridge, bridging their hips up to right about there, keeping like neutral spine, and then really making sure the glutes are pinching to get that contraction. Go ahead and relax. One nice thing that I've tried to do with my glute bridges, I do try to get a little bit more of a core stimulus with arm movements as well. So all the cueing's the same, except for now what I do is I'll add in the band for contraction with their arms. You can do it many different ways. You can do you can do a D2 pattern. You can just have them just move the band. So here's what I like to do. Go ahead and grab the band. And then I'll have them start their arms up just a little bit right through there. And then what I'll have them do is, as they bridge up, one of their arms can move, or she can do them both. So we'll have you actually just do both as your hips bridge up. And go ahead. Good. And then come back. And then I try to follow it just to keep a somewhat consistent resistance as opposed to it getting harder towards the end. I try to keep somewhat consistent of a resistance. And one more time. Good, and then back. Like I said, you can even add diagonal patterns to it. Go and let go of this one. And then we'll have you kind of do kind of like that D2 pattern there. And then go ahead and bridge. And then she can go across by still getting a little bit more of a core stimulus as well. Go and relax. So the glute bridge is a really good exercise to start a little bit early on. A lot of the literature shows that it can be used in late phase 1 of like post-op and early phase 2. The reason for this is because it has a really good high glute activation while minimizing the hip flexor activation as well. Another exercise you can do a little earlier in the rehab phase, but a little bit more advanced than when you're doing the glute bridge, is what would be the prone heel squeeze. Again, this one really has a good advantage of activating your deep external rotators like your piriformis. They can also get some of that glute med as well while keeping your hip flexors like your iliopsoas and pectineus activation really low, so ensuring that you're not getting a lot of impingement in the anterior hip as well. So for the prone heel squeeze, the patient will bring their legs up just like this and have their knees just a little bit out, just around shoulder width, just a little bit more inside of that. And then what they'll do is, it's pretty much in the name, they're just going to squeeze their heels together. Just like that, and then go and relax. Same things like 3 sets of 10, however you like to structure your rehab, just like that. So this would be the prone heel squeeze. Again, it's really used more in like late phase 2, early phase 3 of your post-op protocol when you're starting to get closer to a full active range of motion, able to get more of a contraction through there because the injured tissue is actually starting to heal and you don't have to worry about protecting it as much as phase 1, early phase 2. So as you start progressing through your rehab, you'll be able to start going into more weight-bearing stuff, going into late phase 2, early phase 3. A great exercise once you're able to start going into weight-bearing is the standing hip abduction. So what you'll do is have band around both your knees, above your kneecaps. Now, the location of the band will determine the stress of the actual exercise itself. So this would be a less intense exercise. As it goes lower, say the band down to the ankles or down to the feet, that then increases the resistance of this exercise. This exercise has been shown to have great activation of glute med and glute max. It really gets above 50% a max voluntary isometric contraction. Anything above 40% has been viewed as kind of strengthening. So this is a great exercise to start working into actually getting the strengthening of those gluteal muscles. So really it's pretty simple overall. What I like to have them do is the leg that's going to be on the ground, I like to have them have a slight bend to it. And then what they'll do with the leg that's actually performing the exercise is they just go straight out into abduction. So So the nice thing with this exercise is you're kind of working out both legs. Obviously the one that's moving is going through the concentric contraction. The leg that's down is you're starting to get some stability while their foot is on the ground. So working on not getting that knee valgus during the exercise. So you're actually working out both legs, which is very nice. What I like to do to kind of challenge this exercise is I like to either do like a dual tasking aspect to it. So where I'll throw a ball to them, I'll throw different size balls to them, different colored balls, and then make them tell me what color is coming at them. Or what I like to do is add some perturbations as well. So as they're going through the exercise, I can come through and challenge them this way. So you're still getting that core stimulus and stability stimulus as well. So our last exercise that we're going to go over is the monster walk. So this is great for your end stages of rehab. It's a very challenging exercise. It's full weight bearing, like you're really doing some advanced stuff here. How I have it right now is the difficulty is going to change again, same with the hip abduction exercise where the band is. Right now I have it on what would kind of be the most difficult is having it around your feet. This exercise sits with a little bit lower of activation of the gluteus medius muscle. It sits around 25%. Now, before people start like, nope, never, like, why am I doing this if I'm not strengthening the glutes? With a lower MVIC like this, it actually gives you a good opportunity to start working on muscular endurance, which is very important when you're talking about hip control, right? You don't want to fatigue too early because then you start to have poor hip control later in your competition or exercise. So how I have it right now is actually the higher difficulty because it even adds with the band around the feet, it actually adds that internal rotation torque that the glute, med, and deep external rotators have to overcome. So with the monster walk, how you'll have them is go ahead and feet shoulder width apart and go into a slight bend to your knees. Go ahead and sit back just a little bit more. So have your hips. There you go, perfect. And then what they'll do is they're gonna, with their left leg, they're gonna step kind of out and forward, and then they're gonna come back to that shoulder width, and then on the opposite side, go through there as well. And then same thing, you can have them go for a distance, you can have them go for certain sets. What I like to do is I like to have them go to a distance and then also combined lateral walks as well. This is also great because you can also still add the same things to make it more difficult. You can add perturbations, you can have them do a dual tasking, you can have them dribble a ball, depending on whatever their sport is. So you can still add different tasks to make it a little more challenging and to affect areas of balance and control. So hopefully these techniques kind of give you an idea of at least where to start when you have a patient with hip pain or in particular femoral acetabular impingement. I know when I was a student, a lot of times you learn that like, oh, you need to strengthen glutes or, you know, you do manual therapy, but no one really tells you how do you do that sometimes. And sometimes it could be a little more complex. So I hope this kind of gives you that starting point of I know what exercises have good glute activation. I know what manual therapy techniques I've seen from this video and I can try them.